Thank you, and thanks so much for inviting me. This is my first time coming to this, and I'm very thrilled to be here. And I offer a little bit different perspective in that first I'm a family physician caring through for newborns all the way through the elderly. And also I have a private practice in Arlington, Virginia, which I started back in 2003 with some other primary care physicians. And then I do some academic stuff and then edit the journal. So I have multiple different hats when I'm talking about the issue of breastfeeding. In the last several years, our practice actually joined in this era of ACOs and how we can get by. We went from a very small practice to now we are part of a larger organization called Privia Medical Group. And I am on the board of that group. And what I'm saying is we're constantly looking at how we can make our medical group better, how we can give information and collaborate with primary care physicians and specialists to make patients' health better. And so all of this talk about collaboration, we're in it. I'm in it to collaborate. And so I think it's very good that all of us are here today to talk about the important issue of breastfeeding. So I wanted to talk a little bit about who family physicians are. So as I mentioned, I take care of patients newborn all the way through the elderly. I've had the privilege of having young women patients who then go on to get pregnant, and then I have the honor of becoming their doctor as well. So it's wonderful to be in the full spectrum. Just 2 days ago, I was seeing a new mom and her baby and working with dad too. And mom had preeclampsia, which led to the early delivery. And I set up an appointment. First, I watched them latch in the exam room and made sure that everything was good to go with the breastfeeding. And then set up a follow-up appointment for next week, not only just for the baby, but also for the mom. What if there are mood issues? I want to see how her blood pressure is. Postpartum depression is a huge factor in breastfeeding, so I want to be able to be involved in all of those things. And that's what family physicians do. That's what we are. I love the discussion of collaboration and treating the body as a whole and not in silos. That's pretty much the principles of our discipline. So as I mentioned, we focus on the whole person. We provide comprehensive preventive care, vaccines, well care. We manage a lot of acute and chronic conditions in our patients. And it's continuous and comprehensive. So women's health is important to me. It's important in our practice. I'm fortunate also to work with a medicine peds doctor. And so we've just done a really good job of collaborating and really supporting women and their babies in our practice. Family physicians actually perform over 190 million office visits a year and provide the majority of care for underserved folks. And this is huge. This is, if family physicians are on board with breastfeeding, we can help so many underserved communities. So now I'm going to talk about my American Family Physician hat. So AFP is a peer-reviewed, evidence-based clinical journal, so we don't publish direct research articles. We cover evidence-based scientific review articles on family medicine topics. We are from the American Academy of Family Physicians. However, I'm proud to say we are editorially independent. And we have a readership, as already mentioned, of over 180,000. And we get quite a few web hits, over 26 million unique visits last year. So my point in talking about American Family Physician is that there are a lot of family physicians seeing patients, and American Family Physician is a huge resource that's used by them. Breastfeeding is important to family physicians. It's important to me in my practice, and it's important to the journal. So I'm going to talk about some of the ways family physicians have become familiar with breastfeeding and some of the ways AFP has covered this. So let's talk about some of the resources in general. The American Academy of Family Physicians has a position paper on breastfeeding, and they also have a resource and toolkit, talks about how to implement patient education in your practice, how to advocate in your community. There are even videos, there's even information on billing and coding, all of these things that are to make it more practical so that the day-to-day family physician can start advocating for breastfeeding. And then AFP by topic is a collection of articles in American Family Physician that we basically highlight lots of different types of articles, and we do have a section on breastfeeding, which I'll talk about. So these are some of the things that we've talked about in American Family Physician. And as you can see, they're very practical. So our goal is to help the person who's seeing patients in their practice, who wants to talk about breastfeeding to their patients, wants to help them. How are they going to implement this? So along the lines of what you were saying about we have all this great information, how are we going to make it practical to the people actually delivering care? So one of the things is putting prevention into practice. So American Family Physician highlights the U.S. Preventative Service Tasks Guidelines, and there's a guideline on breastfeeding. And then what we do is we have a department on a case. It's like a case on how you would implement this in practice. How do you use the guideline in practice? So that's what that's about. Then there is impact of breastfeeding support. We have editorials on the topic from the FDA. Then curbside consultation is how you could explain to your patients, encourage them to exclusively breastfeed. And then, of course, the position paper. So I'm going to talk a little bit more about some of that. So let's talk about some of the key points that these articles have shared with readers. First of all, breastfeeding interventions are best done in multiple sessions and multiple points in time as opposed to just a one-off. So meaning that I can't in the exam room just tell my pregnant patient who comes to tell me for the first time that she's pregnant and I congratulate her. I can't say, oh, and remember to breastfeed. Obviously, it's going to be ongoing discussions through time. One of the points was about the FDA's pregnancy and lactation labeling changes and how it transitioned from ABCD in pregnancy to now actually a blurb on what data says about medications both in pregnancy and in lactation. I found it, I use Hippocrates a lot when I see patients, and I've found this information helpful. I also use, it was also LactMed was mentioned in the last talk. I use that all the time in terms of counseling patients on medications. We've already discussed this, but breastfeeding has associated with reductions in breast cancer, diabetes, heart disease, hypertension, and obesity. And then face-to-face breastfeeding interventions are superior to telephone interventions. That doesn't mean that we can't do telephone support, of course, and our group is starting to do a lot more virtual visits, and this could certainly help busy moms and hard to leave the house. I remember it took me about 2 hours the first time I tried to leave my house with my baby for the doctor's appointment. It took about a month to get better. But so there are other ways that we can help to support breastfeeding, but definitely face-to-face and maybe virtually face-to-face can help. And here's some key points from the American Academy of Family Physicians position paper, which we did cover in the journal as well. Of course, we support exclusive breastfeeding, but also recognize that beyond that, there are benefits. If you can maintain and support breastfeeding through age 2, the benefits are even greater. Skin-to-skin contact is important. And also, we need to continue to encourage and discuss breastfeeding with our patients. And we all know that there's not enough education in residencies and medical schools on breastfeeding. So clearly there's a need for this. One of my goals as the editor, and I've been editing American Family Physician for years and years and years, but I've started as the chief editor in February. One of my goals in the coming years is to really work with medical students and residents. These are our future readers. And it's great to help the people reading AFP now, but we need to encourage those who will be reading and implementing what we're writing soon. Breastfeeding is important, and we've covered it extensively, and we have articles in the works right now. And I want to take this information to medical students and residents while they're learning and see that there's a lot of evidence behind it. So it's not just about high blood pressure, it's about knowing the medications you might be using in a woman with high blood pressure who may be breastfeeding. So in summary, I just wanted to, one of the shorter presentations, so it leaves room for questions, but I wanted to say that family physicians have a very important role in breastfeeding. We're here to collaborate. We know there's lots of evidence behind it, and we take care of lots of patients and want to work with groups who are also in the same breastfeeding, who are also behind the evidence on that, and make change. Any questions?
Thank you, Dr. Sexton. That keeps us on schedule. Go ahead, Lucy. Yeah, go ahead. Got the mic.
Right. It's good for mom. It's good for baby. Lots, reams of evidence. But how do you deal with sort of claims being made by patients or perceptions by patients that, hey, as long as the baby gets fed, that's okay. That's what's the most important. And just how do you message around that? And I'm sorry to put you on the spot.
Oh, no, that's okay. I actually have these conversations all the time. The way I mean, it's a very personal thing, right? But the way I break the barrier, first of all, I forgot to mention, we were all, I think a few of us were pregnant when we started our practice, but we were all breastfeeding moms. So I think that for us, has a lot of clout when you're talking to patients. But the first thing I say is, yeah, you're right, as long as the baby gets fed. Because I think that the minute you start saying, oh no, but you're wrong, you're bad if you can't breastfeed, you're really breaking down the communication, and they're not gonna follow through. I've actually recently had one woman who, with her first baby, felt like she couldn't breastfeed and felt like a failure. And then when she came to see me for the second one, she said, well, I'm probably not gonna be able to do it. And I said, why? Why are you not going to be able to do it? There's no reason. And it's okay if you want to start with a little bit of formula, but let's try this. And we just did a few more frequent visits, and then she ended up exclusively breastfeeding her baby. So I think as long as you're, willing to work with them.
Hi, I'm Kara Skelton. I'm from J2 Hopkins. I just had a quick question about the presence of lactation consultants in a family care practice and what your thoughts and perceptions on that. I know there's kind of mixed research on the presence of that and how sometimes pediatricians or family physicians can feel that it interferes with their position. So I just wanted to get your stance on that.
Sure. Personally, I would love to have a lactation consultant. I'd like to have a psychologist. There's a lot of people I'd like to have in my office. So I don't know, at least I'm not speaking academically. I'm speaking in the real world, having worked with lots of family physicians and pediatricians. And I think we want support so we can go on and see our next patient. That's the reality. So for us, other than watching the mom latch and breastfeed, I have a list of resources of lactation consultants who, I've worked with before. And so typically everything has to be done outside of the office unless you are in, a Kaiser or another type of situation where you have the resources to have those people there.
Can I comment on that? I think what I see with that is, I think if family physicians or pediatricians or OBs are having a concern about a lactation consultant interfering with their practice, I think it's because they're not educated into seeing what lactation consultants can do. They're not aware of what they can do. I think that's more so, it's less of a problem now in maybe baby-friendly hospitals where it's part and parcel to the culture in a baby-friendly hospital. But I think most of that comes from lack of education and don't understand what these people do and how they can help. And so they don't make a referral to them. They just give up and say, give the baby a bottle. But I think it's not I don't think it's a concern so much that they're going to take over their practice or interfere with their practice. I think they just need more education, which we need a lot more education for physicians to do things from a breastfeeding standpoint, lactation consultant standpoint, and understanding the teamwork that goes on.
Thank you for your presentation and for the emphasis on collaboration. I'm at an organization that works with governmental public health agencies, so local health departments. And I'm curious if you could talk a little bit about how public health could do a better job of collaborating with folks in your world to promote all of this work.
So in terms, I can't speak for, let's say, the American Academy of Family Physicians because I'm not actively involved in their collaborations. But I will say AFP, and not just on the topic of breastfeeding, but on many of the health topics, we really like to collaborate. Like right now we have things from the U.S. Preventative Service Task Force. We have something coming out from ARC. We have things that have come out from the CDC and FDA, as I mentioned in one of the editorials. So we know we have a huge audience, and it's with care that we need to deliver important evidence-based messages. And it may be that we have excellent family physician authors that can write on that topic, or it may be that we know there are experts in the field at various agencies. And I personally feel it's a responsibility to our readership to give them the best information possible. So that's another reason why I think it's so important to collaborate, because if I'm not going to have access to that information, how can I help those readers that need that information to care for that patient in their room?